Morning, everybody. My name is Kathleen Bartlett. I'm a registered nurse with the North Simcoe Muskoka Hospice Palliative Care Network, and today I'm going to be talking to you about food and fluids at the end of life. How many times have we heard this? If they would only eat or drink something, we know that they would get better. Eating and drinking. In this presentation, we're going to discuss the pros and cons of food and fluids at the end of life, whether or not they're appropriate, what their significance is to family, and how we as healthcare providers can respond to these requests. We need to distinguish between prolonging living and prolonging dying. Parenteral and IV fluids are not needed for comfort at this time. And when we hear the statement, "we can't let him die," it implies that by providing food and fluids that we can make him live. The living versus dying outcome is dictated by disease, not by what you or the family decide to do. By taking fluids, it may actually increase the person's nausea, vomiting, and risk for diarrhea. Extra fluid increase can also increase fluid in the body, in the tissues, which can cause bed sores and overload on other body organs. Fluid may accumulate in the lungs, which compromises breathing and can lead to further issues such as aspiration pneumonia. Dehydration actually causes endorphins to be released into the brain, which produces a natural pain relief and a euphoria for patients. IV fluids do not relieve dry mouth, unlike using a mouth moist swab, or if you just take a washcloth and wet it. Causes of reduction in eating or drinking may be caused from advancing illness, naturally cause a decrease in the appetite. The body is unable to tolerate, digest, absorb, process, and metabolize the food as it once did. Enjoyment of food can be decreased by changing sense of taste, sweeter or more bitter. Altered senses of smell, taste, and texture can also affect hunger. The body can be likened to a factory that's shutting down to the fuel that is used to keep it running, so no matter how much fuel you provide, the body can't metabolize it. Giving food and fluids after a certain point in the disease trajectory can possibly be harmful, causing aspiration, pneumonia, and choking. Hydration. Each decision to start or stop hydration should be made on an ongoing basis and on an individual basis, and depending on the wishes of the person, the stage of the illness, and the goal to be achieved by hydration itself. Earlier on in somebody's illness, hydration can be useful, especially in cases of delirium or an opioid neurotoxicity. If hydration is to be done, hypodermoclysis is less invasive and more comfortable to the patient. In the latter stages, however, the person does not suffer from thirst as stated before. It can actually create a euphoria. Hydration at this point may worsen edema in both the lungs and peripherally. You'll sometimes notice it in their lower extremities and their legs. And there are some cultural or religious beliefs that may be indicated the desire for hydration, but these should be discussed with healthcare providers prior to the terminal phase of someone's illness. What is hypodermoclysis? This is where we give fluid through a sub-Q needle, usually in their arm or their thigh. It can run at about 30 to 80 mils an hour through a needle or plastic cannula. We can do intermittent administration, usually overnight, just so it's more comfortable for the patient and they're not hooked up during the day when visitors are in. They can have up to 100 milliliters an hour of a bolus, which is often tolerated less well, so we don't frequently do that as often. Some considerations. Normal saline is administered by subcutaneous butterfly needle, which is plastic is better than metal because a lot of people tend to react to the metal and you're changing it more frequently. By a gravity flow. Sites include the lower abdomen, thighs, or chest. There is often swelling at the site during the infusion, which is normal. A nutritional supplement such as Boost or Ensure may be acceptable, but it's important to talk to your healthcare provider, as again, this may not be of any benefit to the person. It's important to incorporate all personal rituals and beliefs, so again, talk to your healthcare provider or ask your patient. Nutrition and loss of appetite. Explore what appetite and weight loss means for the patient and their family. It can vary for each person. Educate regarding what may be the causes. Causes can include depression, nausea, poor oral hygiene, dry mouth, or difficulty in swallowing. Mouth sores are also a big issue, or ill-fitting dentures. What is cachexia syndrome? It's caused by an inflammatory state resulting in altered metabolism. There's 3 different stages. The first one is pre-cachexia, the second is cachexia, and the second is refractory. Pre-cachexia may benefit from early nutritional support with a multi-pronged strategy, so incorporating our dietitians, speech language pathologists, physicians, nurses, and other healthcare providers. Number 2, cachexia has very limited benefits. And 3, refractory cachexia does not respond to any interventions. There is also the alternative for artificial nutrition. It is limited benefits for patients with advanced primary cachexia syndrome, but does not improve the quality of life or prolong it. It actually adds burden by having enteral feeding with tubes and risk of aspiration if administered via TPN. The risks are septicemia, so an infection in your blood, electrolyte disturbances, frequent blood draws, and the need for hospitalization. It may be of use when the cause of weight loss is identifiable and reversible, like a dysphagia, so people are having issues swallowing caused by therapy-responsive tumors, or pre-operation treatment of malnutrition in surgically resectable tumors. Some nutritional advice. As the appetite wanes, advise patients to eat what they can, what they enjoy, and what they can tolerate. Set smaller goals. Eat small meals to avoid early satiety and nausea. Add sugar to meals that taste too salty and add salt to meals that taste too sweet. Eat snacks throughout the day rather than 3 large meals, as this may be too much for the patient. If the person has sores in their mouth, like a thrush or cankers, seek treatment. They are often preventable. Fresh pineapple contains enzymes which help to cleanse the mouth, and you can offer hard or sour candies to help produce more saliva if experiencing dry mouth. Again, this is only if the person is capable of holding that candy and not at risk of choking on it. And also for those that describe like a metallic taste, you can use plastic utensils. Some mouth care tips. As the person declines, the need for mouth care increases. It should be provided every hour, and recommended mouth care options include frequent and meticulous mouth care. It's very important for patient comfort, making sure that the mouth is moist and free from sores. We can try offering ice chips, popsicles, tart liquids, or hard candies to simulate salivation. Use a cool mist humidifier at night. Soda water can help to loosen the secretions, or making a baking soda warm water mix that a person can use at the bedside. Oral sprays can increase comfort. Please, please, please do not use petroleum-based products on your lips if you're on oxygen. There is a spark risk. Use a water-based lubricant, so make sure that you're reading the sides of your containers. And then again, for mouth care, apply a moist cloth to keep the lips moist, and use a soft toothbrush or mouth swab to wipe the mouth out. There are some appetite stimulants that we can offer. You can use these when loss of appetite is not related to primary cachexia syndrome, or in the pre-cachexia phase, or for enjoyment of eating when cachexia is advanced. You must explain to the patient and the family that this will not reverse the disease or prolong life to avoid false hope for them. Some of the appetite stimulating medications include omega-3 fatty acids, Nabilone, which is a cannabinoid, Megace and Remeron, and corticosteroids, which are usually for 3 to 4 weeks. It's not the first line agent that we use, but just talk again to your healthcare provider to see if this is an option for your family member or your patient. Some of the final considerations. To see your loved one stop eating and drinking is very difficult, as most know. Education regarding causes and treatments is essential. And when family can no longer show their love through nutrition, guide them to showing their love and nurturing through mouth care, eye drops, massage, music, and conversation uniquely tailored to the care of each individual. I hope that you found this presentation useful. If you have any questions or concerns, just give us a call at the network, 705-325-0505. And thanks for watching.